I'd like to move on now, thanks Philip, to our next speaker, who's Simon Moore, Professor Simon Moore, who's a vet and a professor in the School of Veterinary Medicine in UCD here in Ireland. He's also the director of the Centre for Veterinary Epidemiology and Risk Analysis, or more commonly known as CVERA, where Simon and his team provide very important scientific information which supports policy and decision making in animal health and welfare to aid with animal disease control and in a number of areas. Simon's work doesn't end there. He also works with the European Food Safety Authority, which EFSA, which is a very important organisation which informs European policy on animal health, public health and food policy, where Simon has actually been chair of their scientific committee since 2018. And Simon is going to talk to us this evening about, I suppose, the disease that has impacted on everybody's life for the last nearly 2 years now. As you are aware, NEFIT modelling team have been very influential over the course of the COVID pandemic. And as there was little known, I suppose it's very important, the modelling, how important it has been and useful in guidance to policymakers, particularly as there was so little known about COVID at the start of the pandemic. It was necessary to develop parameters for the development of these models. And Simon and his team played a crucial role in the development of these inputs. So I suppose I'll hand over to Simon, who understands the modelling of COVID and the inputs far better than I do, and he will explain it to you. So over to you, Simon.
Thanks very much, June. And can I just double check you can hear me, June?
I can indeed, yeah.
Okay, so my purpose this evening is essentially to reflect on the veterinary contribution to the national COVID response here in Ireland. Can I take you back to the 1st of June 2020? That was the date for the first case of COVID in Ireland. And I'm sure you would remember the terminology around that point in time where we spoke of seeking to flatten the curve. And in the talk this evening, as June mentioned, I want to particularly speak about what's known as the Irish Epidemiological Modelling Advisory Group. That's the group that Philip Nolan chairs. And it's been a key contributor to NEFIT, to the science. Here's NEFIT here, and here's the Irish Epidemiological Modelling Advisory Group. And you can see there's a number of different groups. And the key thing is, in terms of IMAG, this particular group, there's been expertise across a very broad range of disciplines. And I particularly wanted to focus on veterinary medicine, but as you can see, it's very, very broad. And there's 3 key areas that the group has focused on. And I particularly want to focus on that component relating to the development of epidemiological models, and particularly what's known as the epidemiological parameter team. So the whole point of epi and modelling is firstly to describe what's happening, secondly to try and explain it, and finally to try and predict, essentially ask what if questions. And the important thing, very early on, we first met on the 12th of March, so that's less than a fortnight after the first case in Ireland. For us to build a model, there was a need to really understand this disease. And the important thing is that each disease behaves in a very predictable way, but it's different from disease to disease. And early on, we didn't know a lot about COVID. And if I could just to keep, it's simple, but it's important. If we have an individual and over time that individual is susceptible, then that individual becomes infected, clinical, and has an outcome. Once they're infected, they have an incubation period up until they're clinical, and then they have a period of clinical signs. And that's what we see, but what's important is what we actually don't see. And it has to do with when people become infectious. They have a latent period before they become infectious, and then a period of infectiousness. And we knew from the disease that the other coronavirus that emerged in almost 20 years ago, again from China, we knew at that point that this is what the situation was, that people actually became sick before they became infectious. And this was a person who indeed died from SARS at that point in time. So that was what we had to work on. But in fact, that most definitely is not how COVID has worked. And what I show you here is the final mud map that we put together about our understanding of how COVID behaved. So that was on the 1st of May, which was about 6 weeks after it was initially emerged in Ireland. And we made that a little bit clearer and created this conceptual diagram. And this is indeed how we still understand COVID to work. So people become infected at a point in time, they're infected here, but not infectious. And then they take two routes. Either they're asymptomatic, or else if they are symptomatic, the key thing is that people are infectious for a period before they become symptomatic, this pre-symptomatic period. And that's really important. It's quite the opposite to what we saw with SARS. And it actually is one of the primary reasons why COVID has been so difficult to manage. And then we identified particular routes that people took who were symptomatic. Either they're going to isolate immediately and effectively, they're going to do it, but only after they've been notified, or else they're not going to do it at all. And this diagram really was the basis for the models, and they became much more sophisticated, but this was our biological understanding. And subsequently, that model that I showed you there was a second component was placed on, not just trying to understand the number of cases, the number of symptomatics, the number of asymptomatics, but in terms of the symptomatics, how many of them are hospitalized, how many people end up in critical care. So essentially an extension of the biological model through to hospital demand and capacity. So the work of a team, there was about 14 of us who worked together, was essentially to identify key things that were relevant to this conceptual diagram. We needed to know how long the incubation period of COVID was. We needed to know how much transmission occurs when people are pre-symptomatic versus symptomatic. What's the relative infectiousness of those who are asymptomatic versus those who are symptomatic? And we needed to do this in a manner that was internationally defensible, because clearly it's central to national decision making. So we did a lot of work initially using international data, primarily from China and progressively from Italy as well. But in time, we've also been able to call on Irish data. And as I said, this was a team-based approach, about 14 people, perhaps 50% vets and 50% other colleagues with specialties from the department and also from UCD. Just three very simple modeling concepts. Firstly, it really is a series of mathematical equations, and that's probably all you need to know. The number of susceptibles falls over time. There's a peak in infectious, and then obviously we're going to end up with a build up of recovered people over time. The reproduction number, I think we're all probably experts on this at this point in time, but it's important to be aware that there's actually three things that are important in terms of the reproduction number. Firstly, how the issue of transmissibility, the probability of infection given a contact, the number of contacts per unit time, and also the average duration of the infectious period. These are really critical, and they're really at the basis of all of these measures, apart from vaccination, that have been used in all countries of the world. And then the other thing I just wanted to alert you to, and I'll come back to this, is a concept called force of infection. We're not just interested in the reproduction number, but we're also interested in the underlying level of infection in the population. And I'll explain why shortly. So if we turn the clock back 12 months and we look at late 2020 and early 21, this is Irish data. At that point in time, the reproduction number, using different methods, the reproduction number was all substantially below 1. And things look very comfortable, but indeed it was just prior to the opening up at Christmas time. And a couple of things. Firstly, if you look at this heat map, what we've got here is the weeks of the year. So this first surge that occurred in Ireland in March, April, we can see that it primarily or almost exclusively affects older people. So we've got people by age and we've got weeks of the year here. So the redder the color, the more serious the outbreak. So the early outbreak, as we all know, was mainly associated with very elderly people in nursing homes. Then there was a period of calm, and then in October, what we're seeing here is essentially an outbreak that was affecting all age groups, but particularly young adults. And those numbers of 445, 7-day incident per 100,000, at the moment in Ireland, it's sitting at 3 times that level, by the way. And we'll come back to that in a moment. So things looked comfortable, but in fact, the modelling indicated that the opening up at Christmas time, these were the final models that were developed, the opening up at Christmas time was very dangerous. And the reason for that was partly because with the opening of society, the reproduction number increases, we contact other people more, but also because the underlying level of infection was quite high. So in fact, the force of infection at that point in time was substantial. That's what was modelled, and that's what happened. So the models have been incredibly useful. And you can see here that on the 11th of January, at a point probably one of the most dangerous during the epidemic in Ireland, we're getting reproduction numbers of between 2 and 3. And at one point, I think only on a single day, the incidence rate was higher in Ireland than any other country in the world. And so what happened was, so if we come to that point in time, if we look at this heat map a little bit further, what we saw at the turn of the year, the end of December and the beginning of January, these massive infection levels across society, levels in young adults that are what we're seeing again now. Let's move forward now to a year later, and that is at this point in time. And what we've seen with vaccination, very importantly, is the number of hospitalizations per 1,000 cases has fallen. And that's all because of vaccination. So if you get COVID, the chance of you ending up in hospital is dramatically reduced from where it was. But in the last couple of weeks, we've seen a surge, and we're all very aware of this surge, and I'll provide a little bit more detail shortly. But a key piece of information that's important is when we look at the rise in incidence, so this is the number of cases per 100,000, we look at the rise in incidence, we're not seeing that rise in the elderly. And the reason we're not seeing that rise is because those people have been able to obtain a booster vaccination. So it has provided useful information in terms of some evidence of waning of infection. We move to the models, and these are models from last week. They show, and this is the most optimistic, this is work that Philip Nolan presented last week. This is the most optimistic, and again, it's very much driven by this concept of force of infection. It's almost like the concept of momentum. If you've got a lot of infection to start with and the reproduction number is even a little bit above 1, you end up with dramatic increases. And indeed, the reproduction number last week was substantially above 1. And this was optimistic, looking at by the end of November, looking at between, I guess, most likely 6,000 to 7,000 and potentially much more. The potential for 200,000 cases throughout December. And that's before what's being seen now, changes in behaviour. And as Tony Houlihan, the CMO, has mentioned on multiple occasions, this is a preventable surge, and people are acting very responsibly in response to that. What's important, what is more important at this point in time is not so much the number of cases, that's critical, but more the number of people in hospital, the number of people in ICU. And these are the modelled figures based on that model I showed previously. So I'd like to just move very briefly to bringing it back to a veterinary perspective. There's a lot of work that's ongoing at the moment by veterinarians, particularly in terms of research. seeking to understand risk factors for COVID-19 amongst healthcare workers in several of the biggest hospitals in Ireland. This whole concept of sewage epidemiology, a means to surveil for COVID virus, and also the really tremendous difficulty in terms of transmission of COVID in Irish meat plants. Internationally, colleagues, including Arjan Stegeman from the Netherlands, played a really key role in really disentangling the role of mink in the COVID situation. And internationally, the International Organization for Animal Health has put together advisories, particularly in the context of mink. Finally, in terms of modeling in the context of a veterinary setting, in fact, that is already ongoing. So, and the value of it is in answering what if questions, particularly in the context of Animal Health Ireland. National models have been developed for BVD, are currently being developed for IBR, for JD, and also for TB, in collaboration with modeling experts internationally. And just to show you this graph and the importance of modeling to assist in guiding national policy decision making. So what we have here is actually BVD and the impact of PI retention. And this is based on a model developed by German colleagues, working closely with colleagues within Animal Health Ireland. And up until 2013, basically we had a steady state in terms of the number of infected farms. This is a logarithmic scale. And what we had hoped to see at the beginning of the compulsory phase was a fall, and that fall would continue rapidly towards conclusion. This green line here. So that's what we were hoping for, that in fact we would have eradicated by this point in time. But what became clear was that there was some level of PI retention, and the modelling indicated that if that PI retention continued as it was during that period of time, we would be at this point here, and in fact probably not moving towards eradication at all. But based upon this model, it was possible to see that if we could change that issue of PI retention, and indeed that is what has been done, then we can move towards eradication, as indeed we are doing. In terms of broader perspectives, what we've seen in Ireland, perhaps internationally, is a tension between science and policy. NEFIT advise and government decides. We hear that frequently. And I think this tension is both, is really important. It's important that science is clear in what they think, but it's also important to respect the view that policy needs to make their decisions based on the science, but also on a range of other factors as well. And we see this in veterinary medicine as much as we see it in human medicine. In terms of animal health, there's a need for us to understand complexity. And this is some work done by a colleague looking at movement of cattle in Ireland over 2016. It's an animated map. And the important thing is for us to be able to best control animal health issues, we need to be honest in terms of understanding the complexity that perhaps makes it more difficult to control those issues. Also, another key lesson, partly from COVID, but also from broader experiences, is the real value of farm level data. Internationally, the experience is very clear. If we can measure antimicrobial usage at the farm level, and indeed at the prescriber level, and undertake benchmarking, that's when progress is quickest. And these are other examples, particularly partly from Ireland and particularly from the Netherlands, that really has shown that if you can measure something and if you can benchmark it, you can really make progress. And my final point, I'd like to link back, because this very much focuses on One Health, to the implications of animal health to public health itself. So this is a little bit of an old graph, but what it shows is the number of emerging infectious diseases. These are emerging infectious diseases in people that have occurred over the decades. And the important thing is we can see that the non-black, for example, in this decade here, the non-black, which is animal derived, is much greater than human derived. And indeed, COVID is very much a predictable event given what we understand about emerging infectious diseases. Human emerging infectious diseases, for example, come from wildlife if there's human encroachment, if there's a shift of wild animals to another setting, or indeed if there's ecological manipulation. And human emerging infectious diseases are amplified as a result, for example, of global travel or urbanization, or in some situations also biomedical manipulation. So my final points is that certainly what we've seen with COVID has been seen previously and will certainly be seen again. So SARS, which occurred back almost 20 years ago that I mentioned before, we thought it emerged from palm civets, but in fact, it emerged from Chinese horseshoe bats. And it's likely that COVID has emerged from a similar species of bat, most likely from China. Ebola spilt across to West Africa with a very large outbreak in 2013. It's now known, based on meticulous epidemiological work, that the spillover of infection from this species of bat to a little 2-year-old child occurred at this tree back in December 2013. So June, I hope that provides a little bit of an understanding, firstly, of what veterinarians have contributed to the COVID response, but also some broader reflections in terms of the linkage between veterinary and human medicine. So thanks very much.
Thanks, Simon. That was really interesting. So it was, and great to have the science behind the models explained in a little bit more detail.